I'm going to do a little bit of a commercial, and I'll even let the two of you jump in. Everybody should go to their conference. Just like Vidar just had the experience this last week. Amazing. It really is transformational. And we're going to talk about this later, but the part that for me is so amazing is imagine going to the best healthcare system in the world and spending a week learning about how to do healthcare in a premier way. Imagine all the things you might learn about, the processes, the digital, the computer systems, the way to solve cancer, all these amazing healthcare things, right? Well, you spend 3 days, full days, first 3 days, simply learning from the best in the world how to build trusting relationships. Now, why in the world would you think that an aspirational healthcare model like NUCA would spend 3 days teaching you how to build trusting relationships with people? Give me your thoughts. Why is that so important to the best healthcare system in the world? Patients get better when they trust the provider.
And then the other words that come up when you talk to people, especially people who have been sort of disenfranchised most of their lives, core to their conversation, and again, just to follow April around Juneteenth, and especially Black African-American members of our society, an awful lot of what people say is they want to be seen and they want to be known, and that's a prerequisite for entering into any kind of relationship that's going to have any kind of impact. So I think we're all saying a lot of the same things. I would just add those words to it and strongly follow what April said, which is the core thing is to meet them and follow them on their journey as guests at their table. And this whole professional institutional arrogance has got to go away.
So to your question about trust, I think that healing, we have a lot of healing to do, not just from a physical and emotional and mental health perspective, but we have broken the trust with the American people and our current healthcare system. And so we have to begin healing that broken trust. It's not just starting from building trust from a sort of neutral space. We have a lot of work to do in correcting a broken trust that we've perpetuated.
Somebody said we have harmed trust in healthcare and we have to rebuild. And I just think it's telling that we're having this conversation on Juneteenth, and I just want to acknowledge that distrust in institutions has been a survival mechanism for people, right? It has been the most important thing for your family not to trust what's coming out of the government. It's been successful. I think that Vidar said that you looked at the resiliency and creativity of Native people, and that didn't mean saying yes, sir, to what was coming out of institutions and governments. And we do have a lot of rebuilding to do if we want to really have a meaningful role in the lives of people and families. And the best people to direct us on how to do that are, in fact, those people and families. I'm going to just play a little bit on the comments from the amazing people in the room. I thought they were all really insightful. One of my favorite things about this work we do is that we get to build relationship with people who are thinking differently about healthcare. I heard someone say that patients do better when they trust their providers, and I would turn that around and say healthcare can do better if we trust families and communities to know best what families need. And I heard someone say that patients will be able to comply, right, if we determine what path is going to lead to wellness. And I think in our system we think about that from the opposite perspective too, which is how do we do a good job listening to people and families and using their direction to build a healthcare system that complies with their needs. So really just this play on where power sits, and that trust and relationship is the way that you get to that.
My personal tolerance for words that our staff and other people say is pretty big. And so, we try not to use the word patient anymore. We use customer owner, lots of things in terms of words. But the one that just I don't tolerate is whenever anyone talks about patients being compliant. As April already said, it's the other way around. It's how do we comply with their wants, needs, and wishes and support them on their journey. And to judge people as compliant or non-compliant because they followed or didn't follow what we in our professional and institutional arrogance told them to do is offensive and does harm. and is abusive.
Tonight, we're going to talk about the fourth one, and that is we have to change the front door to healthcare. Why did I buy primary care practices as a hospital administrator? One reason and one reason only. It's a funnel source into the broken system where I can make lots of money. Literally, most every primary care practice in this country on all the networks that we're purchasing for our employees to use are primary care practices that have been purchased up by the healthcare system and held accountable to reach relative value units every day, RVUs. Nothing could be breaking the back of our healthcare, our country than that front door. We have to change the front door. And tonight we're going to talk about the massively powerful primary care system that the best healthcare system in the world has created. And it's my honor to introduce April Kyle, the CEO of South Central Foundation, who created the NUCA system of care, and Dr. Douglas Eby, the medical director. And I'm going to turn it over to them to share their story. Who's going first?
I will jump in, Daryl. That was a lovely introduction. It's good to see you. You were just up in Alaska a couple of days ago. So hello, glad you made it home safe. Maybe we'll just start with introductions briefly. My name is April Kyle. I am Alaska Native on my father's side from a tribe called Ninelchik, which is about 3.5 hours from where I'm standing today. I'm also Russian, and my mom came here from California. That means I'm a customer owner in our system. I've had my babies in our system, and I speak both from the perspective of a leader in our system and also as a mom and a daughter and an auntie and all the things that customer owner means. I've been here for 20 years. I've been in the CEO role for 3, and before that I was our Vice President of Behavioral Services. Doug, you want to say hello to the group?
Doug Eby, I'm a physician executive. I used to once upon a time be a family physician, but I got a master's in public health and administration. Then I became a certified physician executive. I've had tons of training and certifications in quality improvement and complex adaptive systems and all kinds of other stuff. I got really lucky in that I came here 33 years ago, and just over 30 years ago, I was allowed to become the physician partner to the tribal leadership at the time that were in the process of taking over the system from the government. And so this whole system here has been privately owned by Alaska Native corporations and run by Alaska Native people for 25 years. I got to join 30 years ago with the tribal leadership to help scheme the transition and then take the entire system and transform it over time. Just an incredible honor to be allowed to do that. Back to you, April.
So before, I used to have the data slide sort of at the end, and then everyone would hear the philosophy and think, wait, does it work? This is why we have people from across the country and really all over the world coming to look at what we've done. Since we have developed a customer-owned system of care based on relationships, we have seen decrease in ER utilization, hospital utilization, this big recognition Daryl mentioned called Baldrige. But maybe most importantly is that at the beginning of our journey, every outcome, every HEDIS that you wanted to be high on, Alaska Native people were low on. Everything you wanted to be low on, we were high on. I remember in our journey when our goal was to hit the 50th percentile and be mediocre, we are now consistently above the 75th and often at the 90th HEDIS percentile. And we do that by really understanding what our community thinks, so our customer owner satisfaction, and at the same time, how our employees are doing, our employee satisfaction, and really considering those two as balancing measures. And we can talk a lot more about data, but that's just a flavor for why people look at our system. And this is just in general, this idea that if we're going to get to wellness, it's not going to happen because we got the right diagnosis for pink eye and the right prescription today. It's going to happen because we're building relationships with families so that they become increasingly comfortable in being the drivers of their lives, self-confidence and wellness, that they are connected to their culture, that they feel dignity for themselves, and that we become their trusted partner to support them in driving their own success. Next.
So I know most of you are structural operational finance people, and we haven't even gotten to how we structure anything yet. We've just been talking at you about philosophy. And that is the core of what's different about us than other people, is other systems, is that we don't take the as is and then just tinker with it. We actually start with the fundamental assumptions. What are we existing for? who do we exist for, and who then should tell us how the system and the structure should look like. So now we're going to get to a little bit more of structure, and this is what we've sort of established so far. The usual judgmental, paternalistic, at the convenience of the professional medical culture is being replaced with relationship, shared responsibility, customer ownership, story, and if you want to get technical, what is complex adaptive system theory. One more philosophy slide, and then we'll get into specifics. This is kind of, again, because you all have been to way too many years of school, we have to put it into a graphic, and you won't understand it. So this is just a, two variant diagram. So you have acuity on the bottom and control on the left, and it's a percentage. So if you have two variables in a percentage, one has to go down when the other one goes up. So on the far right-hand side, this is about 1/3 of healthcare, 1/3 of healthcare expenditures anyway, which is high acuity environment. So I get hit on the street, EMS scoops me up, does things to me, the ER does things to me, the operating room does things to me, intensive care does things to me. So in those situations, the person or the patient or the customer owner is passive, and the system is doing things to them. On the left-hand side, which is about 2/3 of healthcare, primarily driven by people living with chronic conditions, is a lower acuity environment. And as soon as the customer owner has involvement, they start to control what happens. So whether medications actually get picked up, whether the medications get taken, whether they quit taking them because of side effects or drug-drug interactions, what they eat, how they exercise, whether they use too much tobacco, alcohol, or drugs, what their sleep habits are, whether they lash out violently when frustrated. All these things drive 80 to 95% of their health outcomes and are under their control. So this is not, do we want to give up control? This is acknowledging the fact we've never had control as soon as a person is actively involved in the conversation. So we embraced this rather than sort of being frustrated and said, we're going to completely change everything that we do, since this is actually the reality within which we live. Just one really beautiful picture of our beautiful big 90,000 square foot clinic out in the Mat-Su Valley, just because some visuals are kind of nice. But one of the things we do is create really gorgeous facilities, because the issue of pride, honor, dignity, self-confidence is a very, very major part of the whole conversation. And so how we do facilities and playgrounds and external looks and how much money we spend on the public areas is a very big issue for us, because pride, honor, dignity, we don't want to be that, second-rate safety net native place. We want to be the most beautiful, prestigious, gorgeous, and effective place in town. All right. Here's the structure we're at now, 25 years into this super powerful primary care platform. So in the middle, you have the customer, owner, and family. And then they have one primary care provider who has one case manager who's supported by medical assistants, one or two medical assistants, is something we call a case management support, who's a non-clinical, generally lots of lived experience person from the community who works very directly with the case manager. And those are the people who you're in the most intimate relationship with. They're available to you all day, every day, 5 days a week, period, for anything. And we've tried to make this now into the hub for medical and behavioral and social needs. So anything related to your health, these are the people available, same day access, all day, every day. We've maintained this now for almost 25 years. And then in every single clinic, sitting right with them is the next circle. So there's 2 behaviorists or BHCs. We'd like to get to where there's one on every single team. It's an issue of money and recruitment. We haven't gotten there yet, but ideally your most intimate team is behavioral, medical, and then by extension, social. And in fact, April has made some changes in leadership recently, and the new executive VP for primary care is actually a master's level behavioral health clinician who's also very good at management and senior executive leadership. Well, that's on purpose, because primary care is no longer medical with a little behavioral appendage. It's the hub for absolutely everything happening in your life. So there's two behaviorists, a couple midwives, a clinical pharmacist, a dietitian, and the CRS is community resource specialist. So this is like a placement connect to community services person. And all those people are just co-located, integrated. They don't have separate schedules. This is not co-located mental health. This is integrated behavioral health. And then the next circle out, and people in sort of the olive green on this picture, are people shared across multiple primary care clinics. So they're still physically in primary care, but they're not in every primary care clinic. They're shared across several primary care clinics. So there's 4 psychiatrists, there's an HIV expert, there's home visiting people, there's lactation people, there's people who help you make the most of your electronic health record, there's a fellowship-trained chronic pain specialist, there's a 30-year pain expert psychologist, there are 2 physical therapists who are expert in pain, and then there's some people to help us with high-risk things that occur among Alaska Native people in high proportion, like colorectal cancer. So all these people are physically in primary care, not separate schedules, just all there as resources to be immediately available for whatever people need. So this is how we bring this expertise to people. So addictions, pain, mobility, pregnancy, reproduction, behaviorists, HIV, all that happens in primary care, not as referrals somewhere else. By the way, just a little note, our pediatricians and pediatric case managers are now also in all ages primary care, so that you get a generalist and a pediatric specialist both. You don't have to choose between them when it comes to the health and healthcare of your children. One little outcome, we could talk about outcomes all day. As April said, we moved from the bottom 5th percentile to the top 75th percentile and even the top 90th percentile in just about every single clinical outcome. HIV, I'll just give you the example. We have one HIV specialist nurse who's done nothing but HIV for 20 years, who's in primary care, who helps all the generalists do perfect HIV treatment and support. So you just see your generalist as an HIV positive person. There's no HIV clinic, no HIV Thursdays. You just come when you want to. And the generalist provides perfect support because there's a specialist whispering in their ear to help them do a perfect job. And we have achieved 87% of our HIV individuals have undetectable levels of virus, which is world-class outcomes in a population where we don't get to fire anybody. So our denominator is literally everyone, whereas in HIV clinic outcomes would just be those who choose to go to the HIV clinic. So extremely effective way of doing business. The people on the outside, the pink people on this diagram, those are destination specialists. We still do refer people to specialists who are sitting somewhere else in the system. But even them, we try to train to help the generalists. So like the cardiologists help the generalists with their cardiology challenging people. And in fact, 8 out of 10 potential consults are averted by the cardiologists helping the generalists do a great job with cardiology challenging people, just like the HIV person that I mentioned. So this is the structure. We could spend a whole hour just on this and how all of this plays out, but we don't have time. So I'm going to keep moving ahead. This is just to remind you what I just said. We bring expertise in HIV, diabetes, pain, complexity, sort of generalist complexity. We do a whole thing called aging well, some amount of palliative care. We've co-located psychiatrists, addiction people, pain people. We have home visiting extenders, lactation, midwives, pregnancy, and some amount of sort of logistics related social work, all in what you call primary care. And people say, Doug, you have like the most expensive primary care system in the world, but most of these people already existed. We just reposition where they sit in the system. So these are our population scale approaches. And again, we try to have it be the hub for medical, behavioral, social, and oral health. Same-day access guaranteed for 23 years. 50 to 70% of it asynchronous virtual. People connect with us however they want to, which means primarily this thing called a smartphone. We bring specialists into primary care.
Can you unshare screen, Doug?
I can, but I want them to see this as we close.
The Baldrige Award.
It's better. It's less cost,
Yeah.
happier people, less turnover, better outcomes. It is the triple aim. It is the quadruple aim for less per capita spend, by far about half of the per capita spend that according to U.S. healthcare, we really should be spending. So I will stop share and we'll back to personal relationships.
Awesome. Thank you so much. So couple of things I'd like you to expand on just a little bit as we go into kind of a fireside chat here. The right people for the right job. Doug, I've heard you say in healthcare, we train physicians who are good at tests and know how to build systems, but that's not what we're doing in healthcare. What we're doing in healthcare is getting in the messy experience of being in relationship with people. Talk a little bit about this. There is a certain percent of healthcare that needs to be more of a manufacturing approach, but 70% is that messy, and we need to have the right people in that. And it's not the people who do well on tests often.
If you're spending 20% of society's wealth, which is what has now happened with healthcare, you better be able to explain how you're adding immense value to society. And value, modern medicine thinks value is an accurate diagnosis and giving them a treatment plan. And then we're done. And that's ridiculous. That's not value. Value is them doing something different after encountering us than they would have done had they not encountered us. So getting their meds, taking their meds, following the instructions, changing lifestyle, parenting better and differently, dealing with underlying issues like generational violence, generational trauma, addictions. If they don't do something with what we gave them after they encounter us, we've not added value, which means our number one skill we need to teach and we need to hire for is the ability to influence. So through story, through trusting relationships, through immediate access. If we can't influence, we don't for the 2/3, right? So 1/3, there's value to mechanics. For example, I had a total knee replacement 10 weeks ago. That was mechanical. I need my orthopedic surgeon to be really good at whacking things out and putting things in. So that is 1/3 of healthcare. But 2/3 of healthcare, which is the rapidly escalating cost part, is really about managing chronic conditions. The big ROI here is managing chronic conditions. And then all the wellness and fitness and health is sort of gravy on top. But the real ROI is much better, less expensive people living with chronic conditions that they are in control of. So our ability to influence is where you get value, not diagnosis, treatment plan, and then judging them not compliant. April, you want to add?
Yeah, Doug, can I just add to that? I echo everything Doug said. And if you take that one step farther and you say, okay, how does a healthcare system become in relationship in a way where we can provide influence? And the answer to that question is to ourselves as humans be in relationship with community and planfully intend to be influenced, right? To be influenced by what community and families tell us matters in their lives. What are the ways that we can be their partner and be in their lives differently than how, a doc who likes Fridays off to golf and thinks that the system's going to be built around him and the payer and what they think you're going to do and the law and what they think you're going to do. But instead, what does family think? And can we have a trusting relationship enough to create voice for families to tell us and to be willing to be influenced to design what we do differently so that we, through that relationship, can then influence them. You see how that goes back and forth?
Well, and expand on that if you don't mind. How do your provider teams really get that last hardest group to move? I know you've referred to your medical assistant support people as your secret sauce. Talk a little bit about that.
Yeah, so as April said, when we started all this, we thought we were being really aggressive and brave and proposed to our board that we try and get to the 50th percentile on health outcomes because we were in the 5th. We were the bottom 5th. And we thought that was really aggressive. And our board actually scoffed at us and said, oh, so you want to be average? And we said, yeah, we're a long way from average. And they said, no, we're going to be above average. So that was the 75th percentile. And just through sheer really good general relationship and clinical acumen and partnering and all that, we do pretty much all our teams get to 75th percentile performance. But there have now been 5 clinical teams that have moved every one of their clinical indicators to the 90th percentile. And I'll go spend a half a day with any team that accomplishes that. And every single one of them says the way they moved that last bit was by working through their case management support, which are almost all middle-aged women who have had kind of hard lives and a lot of lived experience and know just how to talk and relate and work with people who are hard to reach and hard to influence to do something different than they would otherwise do. And this goes back to just the fact that if you're going to get to cost in healthcare and outcomes, you have to remember that 80-20, that 20% of people are going to drive 80% of cost. And those 20% of people, by and large, are not your most confident, not your most self-capable, not your show up on time for appointment people. They're some of the most challenged, hardest to reach, don't come in, miss appointments, come late to appointments, and our rigid, you must show up on time or you won't be seen. And, you know, at our convenience in our institutions, I mean, so let's just play out the average encounter, right? So you have to take off of work, you have to arrange childcare, or you have to get transportation. And then you get a hold of us and we make you wait 2, 3, 4 weeks before we even see you. Then you have to make this massive effort. To have a healthcare appointment is at least a half day, if not a full day effort. And a lot of these folks are working 2 and 3 jobs. It doesn't want to give them a lot of time off. And then they have to come across town, and then we make them wait when they show up. And then we rush them through, and then we don't let them say hardly anything. We tell them, here's your label, call it a diagnosis, here's your plan, and if you don't do what I said, we'll call you non-compliant when you come back. I mean, literally everything about that is horribly designed if you're actually trying to get to the 20% of people who drive the vast majority of healthcare costs. Completely ridiculous from a population health and the fact we now control 20% of this nation's wealth. And the return on that investment is terrible. I think we just spent the last 45 minutes trying to convince you that relationship and connecting and story and trust and meeting them where they are on their journey is the magic here. It's not just the technical delivery of knowledge and the access to prescribing and pharmaceuticals and tests and whatever. That's all secondary. People have to take ownership of their journey. We have to meet them where they are. We have to support them on their journey. They have to trust, and then they have to do something different after encountering us. And the ability to get people to do that, especially the 20% that drive 80% of the cost, is very, very low if you don't have some human element of connection and trust and story.
Talk about your approach, which is aspirational, versus epidemiologist's approach, which is deficit.
Oh, that's a trigger.
We have a tribal leader on our board where this is a passion conversation for her. What good does it do when academia labels all of the problems with Alaska Native people? And if you wanted to write a paper on that, you want to research it and you want to publish all the ways we're bad, you could do it. And what will you have done? You'll have harmed and hurt a generation. What if instead of that, instead of the ACEs, we're going to label the number of times that you've been harmed and tell you that that's going to be the driver of what happens next? What if instead of that, we were able to really quantify our resilience and our strength and our relationships, our creativity? I hope that if you tell someone about this talk, you don't say that Doug Eby was really great or April Kyle. I hope what you say is that Alaska Native people are doing something really amazing. Look how strong they are. And Daryl, it's a very leading question because I think you know our answer to it, which is we can choose the paradigm that we want to think about, and we can have an illness, diagnosis, treatment, symptoms-based, or we can talk about resiliency and recovery and strength and dignity and pride. And those are choices that we make. And we've been making the wrong choices for a long time.
Epidemiology just means the study of a population and their health attributes. Unfortunately, medical people list nothing but the negatives. And there's nothing about the definition of epidemiology that says it has to be that way. You can list just all the positives, enumerate all the bright spots, and across different locations, what are those things in common? And then that tells you what to fund and support in order to move everyone to a better place. There's no reason epidemiology has to be 100% negative as it currently is. It's the oppression of the medical model, once again, doing harm.
Thank you. Lee, do you want to talk about the HTA movement? And if you got questions relative to that here, and then we're going to open it up for just general questions. Stand or sit right here. Okay.
Yes. So, Doug and April, in conversations with you and others, it's become apparent. I work with large employers, mostly in the lower 48, who have, who are operating in 2,000 or 3,000 U.S. cities. So they're all over the place, every state, every time zone. About 5 million total families, and we've seen that primary care is evaporating. At best, you get 2 months of wait time for 5 minutes. At worst, you're just going into a place where they're incentivized to refer. So we said, okay, we need more independent primary care. Where can we find them? We have been successful in finding independent, value-based primary care down here in the lower 48 in different cities and towns who are taking a subscription-based payment rather than fee-for-service. So they're aligning the incentives that way. They are, by and large, integrated in their communities, and they're often fairly entrepreneurial. They're not all highly standardized, but they are engaging in different ways to deliver great care. And so the problem, though, is that all of them say, hey, I don't take insurance. You got to pay me just a flat regular fee. And I don't know how to bill claims, or maybe I could, but I'm not going to tell you anyways because I don't do that. That's not how we operate, right? And then I go to my large employers and say, hey, we need to work with these. Like step one, we've got to get value-based, aligned incentive access with a physician who we can see and visit and build a relationship with, right? Like that's our first baby step. And the problem, though, is that in order to pay these people directly, either the patient's paying cash, and about 86% of our people can't afford to. And if we give them money to pay cash, they will spend it on groceries. They're not going to go and pay the subscription to the doctors. So we have to find a way to pay these physicians directly for the majority of our population who they're just not going to do that expense on their own. And unfortunately, if you're a large, Fortune 30 company with 300,000 families that you're covering, you can't do 1,000 little onesie-twosie contracts with different primary care all across the country. And you have to use the system you've got to pay them, which is an insurance company. So we had this huge problem. So after working on it for 3 years, banging our head against the wall, redesigning the program probably in excess of 70 or 80 times, we now have a model that is enabling us to activate independent, value-based, membership-based primary care sort of across the country, and pay them a membership fee on behalf of our employees through an insurance company without forcing the providers to change their operating model. This is necessary, but it's not sufficient. This is still just our first step, right? When we look at your concentric circles, we're just trying to get, I think we've got 3 of the little images of people in your center circle, and we don't have any of the other stuff yet, right? We don't have the olive green or the pink outsiders or any of the others yet. So we're just getting a baby step, but we believe that if we can lock down that coverage in cities and towns across the country, we can have an open dialogue. We're paying them a value-based care, and then our hope is over the next 2, 3, 4, 5 years, we can start to follow your example a little bit and start to integrate more of those personas. We can get our AIDS specialist and our colorectal screening person. Maybe it's not colorectal screening in the lower 48, right? Maybe it's, I don't know, just something in cardiology or something like that. But we'll be able to start getting our personas that we can start connecting into this system and do that across the country. That's our hope. And that by having highly thoughtful referrals, we can start to choke off profiteering systems so that there is a consequence for profiteering, that you just don't have patients show up anymore. And hopefully that starts to realign incentives downstream.
Do you want to take questions?
Absolutely, yeah.
Anybody have questions for Lee?
either Deb or April or May.
So my question is, if this is a baby step, fast forward 5 long years, we will have lived through even more consolidation, vertical and horizontal. Will there be an ecosystem there to continue building out those concentric circles in 5 years, given the pace of consolidation in the market? That concerns me.
This is my thought on that, because I think about this every day. There are two competing incentives that are both extremely forceful. One of them is the profit motive in the carriers and the hospitals who are doing exactly what you say. They are buying up every doctor, locking down access. All of our specialists are on somebody else's payroll. The other counter incentive or rebellious insurgency appears to be heavy dissatisfaction among all those individuals who absolutely hate the predicament they find themselves in. And in speaking with our physicians, it's funny, we talked to doctors in the different towns. We were in Rochester. Rochester is a desert for value-based care, for instance. Just weirdly, as a bit of trivia, there's only one direct primary care physician in Rochester, Dr. Petrovic. She's this highly rebellious, I think she's Russian. I'm not sure, but she's like, everyone tells me not to do it, but I said, I'm doing it anyway, and to heck with them, and she sort of breaks out. She says, I take care of my patient, every patient, top to bottom. You can buy insurance if you want, but you just need Dr. P. So in visiting with her and others, it's apparent. We said, well, hey, if we can fill up your office, what do we do next? Because I've got 10,000 families in Rochester. The greater metro area has over 1 million people, and there's only Dr. P. And she says, oh, I have like 20 friends who are all begging me to do this. She's like, everyone wants to escape the system. So we've been thinking, I keep thinking of it as I call it a necromancer effect. We need to bring these people back out of where they've gone to rest, and we need to bring them back into independence. But I feel like there might be a way to accomplish that if we can drive enough business and demand into value-based care that will draw people back out of the beast. My hope.
Can I make a comment on that?
Sure.
I just wanted to say that I think that if we do healthcare better, that the folks who got into this field for a reason are going to be attracted to that, right? And so when you think about what will be the drivers of what healthcare will look like in 5 years, I agree with the concern around consolidation and powers of big systems and hospitals, but I also think there's going to be some power in the vote with your feet workforce, who are going to want to be in places where they can make a difference. And just from a workforce perspective, I think the other thing that's worth thinking about that, I think we said a little bit about is that wellness doesn't always come from talking to somebody with lots of initials. There's a lot of ways by bringing community together for people in like experiences. We call them learning circles. Or by talking with a community member who speaks like you and lives in the same kind of place where you live, you can have a real conversation about a mammogram or a colonoscopy. I think that thinking about workforce differently and the places that can really attract that workforce to deliver care are going to have, they're going to have a foothold, and that's something to build on.
I have a question for you, Doug and April. As we think about this, the future that we want, where we are coaxing the right kind of people to leave the W-2 working for Optum and come back out and become independent again, while they're with Optum or with the local health system fee for service, they've got 3,000 patients. We think that's too many. Everyone acknowledges that that's not even real. We bring them back out and now they have 800 patients. Am I leaving 2,200 families out to dry every time I convert one over. I don't think that's the case. I think that also might get back to the concentric circles, but I need your advice on how I should think about that.
So because I'll answer first and I'll pass to Doug. Because we're responsible for the entire Alaska Native community that resides in our area, I always give pause to the idea that we're going to create something boutique that people who can afford it will get it, and figure out how we can ensure that what we're building is really accessible to everyone. And that's just a value premise that I have as we rethink what the U.S. healthcare system can really look like. And I'll just mention, I think Daryl said this, that when we just came out of last week having our NUCA conference where we had, it's a small conference, 150 guests come from all over the world. It's not a lot of U.S. healthcare because what we're doing is much more like sort of population health. But I think that if you're afraid to pull people into a better system for fear that you make the worst system worse again, we'll never get anywhere.
Yeah.
Do you want to add to that, Doug?
Oh, yeah. Do I have 15, 20 minutes?
Yeah.
Several comments. So when we tell our story of what we've done, it's not uncommon for there to be an older physician who speaks up and says, oh, that's how we used to be. You know, the country doc who was, you know, knew everybody, knew the grandma, grandpa, the aunties, the uncles, and followed them all for life and got great trust, and, you know, saw them in the grocery store and saw them in the football game and so forth. So my answer to that is yes, actually, we have recreated the old country doc, but on a much more sophisticated platform with a whole lot more teammates. So my problem with the small panel concierge practice is that it's still very doctor-centric and not scalable to whole populations or the whole country, and very kind of VIP exclusive. And they tend to skim off the top. They tend to get the, you know, personally motivated, high self-confidence person who can afford to pay an individual premium, and the whole, you know, 20% driving 80% of the cost. Very few of those people can play in that game. So I understand the attractiveness of the boutique, you know, don't take insurance, give me a fee, and I'll give you concierge service thing. But I think it's terrible, and I think it's destructive to our society. Our society helped pay for the education of every one of those doctors, and they owe society. And so I believe in the country doctor relationship part, but with very extensive teammates and in a very sophisticated platform. So I think part of the answer here is, rather than mega corporations that people sign up with instead of United, you know, United Health this way and NUCA this way, that there's room for especially employers, people with money, so government, employers, to create infrastructures that can support people in lots of different hiring realities. So yes, you can be your own independent practicing physician, but you sign up with us and we'll give you the data, the evaluations, the whole system support, and all the training, and we'll help you build more integrated teams and all that kind of stuff. You don't have to be employed by us, but we represent employers and payers, and we're going to provide the infrastructure on which your individual work can then happen. So I think there's a lot of ways to do this, and this isn't a 5-minute conversation. I think what's the economic and employment and structural platforms that can make this happen? I think there's a lot of ways to do it. One other thing, if you're running out of doctors, like in our system, we employ twice as many PAs and nurse practitioners as we do doctors. Mostly they're not primary care providers. Mostly they're coverage people, helping cover when people are out and so forth. But some of the super good PAs and nurse practitioners are primary care providers and have their own panels and so forth. So if we did get to the point where we had 1/3 as many doctors as we currently have, we just make them more the tip of the iceberg. They would do less and less, and they would be more and more the sort of sponsor of all kinds of other people. If you take a good nurse and a good pharmacist, you really don't need a doctor. If you take a good nurse, a good pharmacist, and a home visitor, you really hardly need a doctor. And if you throw a PA or nurse practitioner in there, you really don't need a doctor. So this doctor-centric thing and these little concierge practices are very doctor-centric. And that's just not scalable to a whole society. Not that I have opinions on anything.
But to me, when you're thinking about, so there's a couple ways to think about change. A lot of people talk about change as being tinkering around the edges improvement. What we did was whole system redesign, walking away from the medical model and building something new. And for me, when we did that, what was important is to land the philosophy and the why in a really, really strong way, to know what you're seeking to do and to be steadfast in doing that. And how you do it, you're going to have to try and learn, but to know that's what you're going to do. And somebody said that the providers that you know that are doing this well, and I can think of one in Alaska doing this well that just is private pay, right? They just don't do insurance because there's so many drivers against doing the right thing. And I don't buy that you have to do that. So, for example, when I was leading behavioral health and we were thinking about redesigning what access looks like to addiction treatment, for example, as we are redesigning, it is so hard in U.S. healthcare not to be completely driven by regulation and Medicaid plan and what insurance will pay and what Medicare will pay and kind of all of these things. And all of a sudden, all you're doing is checking the box for all of those payers, that we had to intentionally remind ourselves that we were going to do this by banking all of our assets in building relationship, real human relationship amongst provider teams and between provider teams and families. And if we could really walk with them in their journey, then we could get to wellness. And so I say as a leader, there is a bunch of laws and regulations and pressures up here, but I'm going to hold them up here and allow for the space for the creativity to do the right thing to happen. And the joke is, that means if the right intervention is to build a canoe, then I'm going to go and tell Medicare and Medicaid and insurers how that fits into their model of how they should pay us, because it counts. And when I say build a canoe, I actually literally mean that the right thing to do might be to go build a canoe. And so that kind of canoe idea, like what should we do versus what are those pressures? You have to just acknowledge them, and then at the high end, figure out the finances to run the business, follow all the laws, but not let that be the drivers, that the day-to-day interactions that provider teams have can just be doing the right thing in relationship with families in front of them.
Totally agree with April, and I would just add from a financial management perspective, a lot of people refer to us as wellness and prevention and population health and public health, which is all true. But financially, the big seller for doing what we do is the ROI on chronic disease management. Mm-hmm. So the short term, I mean, within 18 to 24 months of a full institution of a system like ours, you can, I mean, look at that data we gave you on the second slide. The amount of cost spent on people living with chronic conditions plummets, because we're just way more effective at influencing people to do the things we know that work to help keep you out of the hospital and living independently. So there is a big ROI, I mean, and not long, 18, 24 months, big ROI on the most influenceable chronic disease management conditions. And then the rest of it follows from there. And eventually you get to all the other stuff that helps just make for healthier lives and healthier families and all of that other wonderfully good stuff. But if you need to make a financial argument with the people that have the money, so, if I were dictator of the world, I'd start with people who have the money and get them to fund something different than they currently fund. Which is why I believe you have this guy named Daryl who's a bit obsessed with employers because they have a lot of the money that pays for healthcare. So there, Daryl, did we bring it full circle in the end?